Now, we often see fluid in the renal collecting system, and so it's important to evaluate this to see if the fetus in fact has hydronephrosis. We diagnose hydronephrosis when we see dilated calyces as well as a dilated renal pelvis, or if the dilated renal pelvis measures 7 millimeters or more at 16 to 20 weeks, or 10 millimeters or more after 20 weeks. Sometimes, though, we see fluid in the kidney that is not as large as I listed up here, and for those cases, rather than discount them and call them normal, we call those possible hydronephrosis, and that's when the dilated renal pelvis measures 4 to 6 millimeters from 16 to 20 weeks, or 5 to 9 millimeters after 20 weeks. It's important to identify these fetuses because about 10% of them will have significant problems after birth from mild either reflux or obstruction. So here's a fetus at 18 weeks gestation. You can see that there's fluid in both of the renal pelvises, in each of the kidneys on either side of the spine. And when we measure the anterior-posterior dimension of the renal pelvis, we see that it's 6 millimeters on each side. So this would be classified as possible hydronephrosis for this fetus. This fetus is 32 weeks gestation. You can see again that posterior view of the back of the fetus with the spine here and the shadowing behind it, and we can see that one kidney is dilated to almost 9 millimeters, the other kidney is dilated to 10 millimeters. So this is a case of hydronephrosis that should be followed after birth. The pediatrician should be alerted to this anomaly. This fetus has fairly severe hydronephrosis. You can see that there are marked dilated calyces throughout the kidney, so this is marked caliectasis and a definitive diagnosis of hydronephrosis. Hydronephrosis typically should be followed when it's first diagnosed in utero because during gestation it might resolve, but it also might progress to become more severe. So we do tend to follow these to see whether they do resolve, stay the same, or become worse. It's important to follow these not necessarily through gestation, but at least one time to see whether there is any progression. So here's a fetus who demonstrated progressive hydronephrosis. At 18 weeks gestation, actually, the kidneys were normal. You can see a transverse view of the fetal abdomen. In this case, the spine is down on the image, and on either side, the kidneys showed no dilated pelvises on either side. But here the fetus now is at 34 weeks gestation, and you can see that one kidney has a dilated renal pelvis of 9 millimeters. The other kidney, though, has a markedly dilated renal pelvis at 16 millimeters, as well as caliectasis. So this had progressed from no hydronephrosis to fairly severe hydronephrosis in the intervening 16 weeks. Now, hydronephrosis can be caused from a number of different reasons. It can result from obstruction at the ureteropelvic junction, and this is something that's seen more commonly in males than female fetuses with a ratio of about 5 to 1. You can also have obstruction at the level of the distal ureter, and this is something we see with primary megaureter. Vesicoureteral reflux causes dilated kidney and ureter, and so we will diagnose that as hydronephrosis. In addition, bladder outlet obstruction with either posterior urethral valves or prune belly syndrome causes hydronephrosis. Notice that these syndromes or problems related to drainage of urine from the kidneys to the bladder are all more common in males than in females, and in particular the last two diagnoses, posterior urethral valves and prune belly syndrome, are seen exclusively in male fetuses. Ureteropelvic junction obstruction is the most common cause of neonatal hydronephrosis. It's a functional obstruction. That is, there's not a web or anything across the ureter. It's just more of a kink that's partial and therefore does allow some urine to pass through. About 30% of fetuses have this in both kidneys. And fortunately, because the obstruction is functional, it rarely develops into a dysplastic kidney. So here's a fetus with bilateral ureteropelvic junction obstruction. You can see on a transverse view of the fetal abdomen, there's fluid in both renal pelvises. It measures 10 millimeters on one side and 9 millimeters on the other. And a longitudinal view of the kidney shows that we have dilated calyces as well. This fetus has fairly severe bilateral ureteropelvic junction obstruction. You can see that there's a marked amount of fluid in each of the renal pelvises, and the measurements as listed here show that the right renal pelvis measured 16 millimeters and the left 23 millimeters. But you'll also notice that the amniotic fluid around this fetus is normal, and that's because the renal function is normal and the fetus is able to make urine, and the bladder is able to empty it and replenish the amniotic fluid. Now, vesicoureteral reflux occurs when there's abnormal insertion of the ureter into the urinary bladder. The reflux allows urine to climb back up from the bladder into the ureter and even into the kidney, and so on ultrasound we'll see hydronephrosis and hydroureter. The differential diagnosis of the findings of hydronephrosis and hydroureter includes primary megaureter. What's the difference? Well, there is no difference in ultrasound findings with primary megaureter when compared to vesicoureteral reflux, but the pathology is very different. With primary megaureter, you have an aperistaltic segment of the distal ureter that does not allow the urine to drain properly from the kidney into the bladder. So here's a fetus who has hydronephrosis and hydroureter on one side. You can see on a view of the kidneys on either side of the spine that there's mild pelvic dilatation on one side and greater dilatation on the other, where the renal pelvis measures 12.5 millimeters. On the side of the larger dilatation, we were able to identify a dilated tortuous ureter extending from the dilated kidney, which is here, to the bladder. And so this was hydronephrosis and hydroureter. And there's no way in utero to know whether this is reflux or primary megaureter. Renal duplication is when the kidney develops with two regions of the collecting system and two ureters that travel down to the bladder. This is more common in females than it is in males. While this can be a normal finding and renal function can be normal, it also can cause problems. Sometimes the upper pole ureter will become obstructed, and it's not uncommon to have reflux into the lower pole ureter. So we identify this in ureter, particularly when there's hydronephrosis in the affected kidney. On ultrasound, a duplicated kidney will have an elongated kidney that measures longer than it should for gestational age. And we may see fluid in the collecting system that is not the same throughout the kidney. We'll have differential hydronephrosis with more fluid in the upper pole than the lower pole. We also may be able to identify an ectopic ureter in the bladder if the upper pole ureter inserts abnormally. So here is a diagram of what renal duplication looks like in the fetus. When there is no obstruction, you can see that the duplicated kidney is longer than the contralateral kidney and that there are two ureters, and typically the upper pole ureter will travel lower into the bladder and insert than the lower pole ureter. Now, if both insertions work properly, you'll have no obstruction and no reflux. And here is a fetus where there's renal duplication that was not a problem for the fetus. You can see that the normal left kidney is much smaller than the enlarged right kidney, which had two small areas of fluid, normal amount of fluid in the region of both parts of the collecting system. When the upper pole of the upper pole ureter is obstructed, you'll get dilated ureter and dilated kidney in the upper pole of it. This is another diagram showing this in a fetus. You can see that the lower pole ureter is normal and inserts appropriately, but the upper pole ureter inserts in an aberrant location such that it doesn't drain into the bladder properly, and so you have dilatation of that ureter as well as dilatation inside the kidney. And here is a fetus with a renal duplication and asymmetric dilatation of the collecting system. You can see that the normal kidney is being measured and it measures 4.1 centimeters. Compare that to the contralateral duplicated kidney, which measures 5.2 centimeters. So we already have a clue that this kidney is different. And when we look closely at the collecting system on the right side, we can see fluid in the lower pole collecting system separate from the fluid in the upper pole, which is more dilated than the lower pole. Looking even more carefully, we were able to identify the dilated ureter that drains the fluid from this collecting system down into the bladder, but in an obstructed location, so there's backup of urine in the ureter and in the upper pole of the kidney. Here's another fetus with renal duplication. You can see an enlarged kidney with duplication of the collecting systems and dilatation only of the upper pole calyces and pelvis and proximal portion of the upper pole ureter. When we got down to the bladder, we were able to identify what's called a ureterocele. This is where that ureter is obstructed because it's not draining properly. It is obstructed at this point with a backup of urine into the ureter and into the upper pole.